Thank you very much, David, and I appreciate the organizing committee inviting me to give this talk. This is my conflict of interest disclosure. So once the results of the Syntax trial were presented, this is a very common interpretation that we heard from the interventional cardiology community. In Syntax, all we're doing with CABG is trading a stroke for repeat revascularization. Now, who would want that? Of course, repeat revascularization is not as big a deal as stroke. So therefore, even though MACE was higher due to repeat revascularization in the PCI arm, that's okay because at least the patients aren't getting a stroke. And I think that there is some validity to this criticism, and it's incumbent upon us to look at the stroke issue with CABG and see what the issues are and what we can potentially do to improve it, and that's the purpose of this presentation. Now, by way of background, if we look at what the data is for stroke of CABG versus PCI, and stroke is defined as a neurologic deficit lasting greater than 72 hours, occurring in the hospital in 30 days. If we look at the STS database for CABG, in a 5-year time period of 774,000 patients, the stroke rate is 1.4%. For PCI, in the ACC database, at approximately the same period of time and approximately the same number of patients, the stroke rate is 0.2%, so 1/7 of what it is with CABG. So the objectives of this study were to assess the stroke rate in Syntax, define the risk factors and outcomes of patients who experience a stroke. By protocol, stroke was defined as follows. A transient ischemic attack was a focal neurologic deficit lasting less than 24 hours, and a cerebrovascular accident was a focal neurologic deficit lasting greater than 72 hours with irreversible brain damage or permanent impairment. It was further classified as ischemic or hemorrhagic. All strokes were confirmed by a local neurologist, and it was all adjudicated by a clinical events committee, which did include a neurologist. So this is the familiar Syntax outline that you see, and 97% of the patients had 1-year follow-up, which is 849 patients in the CABG arm, 891 in the Taxus. There were 19 strokes occur in the CABG arm and 5 strokes occurring in the PCI arm. If we look at the basic characteristics between the two arms of the study, there is no significant difference. This is the usual risk factors that we see. If we look at more potential risk factors for stroke, we see that the only possible difference is here is that there were more smokers, current smokers in the CABG arm than the Taxus arm. However, it didn't quite reach statistical significance. Now, if we look at procedural characteristics that may be potential risk factors for stroke, there's a couple things that stand out. One is that there were a statistically higher significant number of emergent procedures occurring in the CABG arm, 3.9 versus 1.8%. And importantly, the time from randomization till the patient actually got the procedure was significantly different. 17 days for CABG and 7 days for Taxus. Now this is important because the results of this trial, as are most trials, are intent to treat analysis. So the further time between randomization and actually getting the procedure, if an event occurs then, it still counts. So we'll see why that's important in just a minute. If we also look, 15% of the CABG patients were treated off pump, which is a low number. However, if we look at the stroke off pump and on pump, only 1 of the 19 strokes occurred in the off pump group. So of 134 patients, a stroke rate of 0.7%. 18 of the 19 strokes occurred in the on-pump group. However, this wasn't statistically significant because of the low percentage of patients performed off-pump. If we look at other potential risk factors, and let's look first of all at pre- and peri-procedural medication, what stands out here is that only 1% of the patients, as you would expect, received clopidogrel around the time of the procedure, whereas virtually all the Texas patients did. If we look at medications at discharge, we see that 20% of the CABG patients and almost 100% of the PCI patients received dual antiplatelet therapy, raising the question after the procedure, is this perhaps protective from stroke? If we look at the medications at 12 months, again we see that only 15% of the patients are on dual antiplatelet therapy, while 71% of the Texas patients were at 1 year. So now if we look at the stroke rate to 12 months, this is at the primary endpoint of the trial, we can see that it's almost 4 times higher in CABG than it is with PCI, 2.2 versus 0.6%, which is highly statistically significant. If we look at the timing of when the stroke occurred, and if we look at the vertical line here as the time the patient has the procedure, you can see that some of the strokes occurred before the procedure, some during the peri-procedural period, but a significant number, 37%, occurred late after the procedure, but before a year. If we look at the PCI arm, none of the strokes occurred before the procedure, only 1 in the peri-procedural period, with the other 4 occurring late after the procedure. If we look at the type of stroke, 17 of the 19 were ischemic with 2 hemorrhagic in the CABG arm. In the PCI arm, 3 of the 5 were ischemic and 2 were hemorrhagic. Of the hemorrhagic strokes in the CABG arm, 1 occurred 7 days post-randomization but before the procedure, so that patient never had CABG. And the second was a stroke that occurred 241 days after the procedure. If we look at the antiplatelet therapy, at the time the patient had a stroke, of the 19 patients in the CABG arm, 52% were on aspirin. Only 1 patient was on dual antiplatelet therapy. If we look at the PCI arm, 4 of the 5 were on antiplatelet therapy and 1 was unknown. If we look at whether the stroke was associated with adverse cardiac events or not, in 6 patients, the stroke was associated with an adverse event. In 3 of those patients, it was atrial fibrillation. 13 patients had a stroke independent of another cardiac event. In the PCI arm, 3 of the 5 strokes occurred associated with another cardiac event. If we look at the outcomes following stroke, 2 of the 19 patients that had a stroke in CABG died. The other 17 were non-fatal. 4 of the 19 strokes resolved without residual neurologic deficit. There were no fatal strokes in the PCI arm, and 2 of the strokes resolved without permanent neurologic deficit. If we then look at the incidence of stroke by Syntax score, we see that there is no relationship at all with stroke occurring equally independent of the complexity of the coronary anatomy. If we then analyze it and look at overall predictors by multivariate analysis, we can see that for overall revascularization of the overall trial, poor or moderate depression of left ventricular function was an independent risk factor for stroke. If we then look at it by arm, we again see in the CABG arm that poor or moderate left ventricular function was an independent predictor with an odds ratio of 6.3. There were no independent predictors for stroke in the Texas arm, probably because of the low number of strokes occurring. Now, Peter just presented the 2-year results of that trial, and we see now that the incidence is 2.8% in CABG and 1.4%. You can see that after 1 year, 0.6% in CABG and 0.7% in PCI, so that there was no difference occurring after that. So summary of the incidence of stroke in the trial, it was low at 1 year. There were significantly more strokes in CABG than with Taxus. Significantly more Taxus patients received pre- and peri-procedural antiplatelet therapy. A greater proportion of the stroke in strokes occurred peri-procedurally in CABG. The majority were ischemic, and poor or moderate left ventricular function was the strongest predictor and increased the risk of stroke. So what are the lessons or questions that are raised from the CABG arm? Well, I think from a surgeon's standpoint, we have to look at a couple. One is, what is the role of off-pump surgery, especially in high-risk patients? Two is, a significant number of these strokes were associated with atrial fibrillation. And should we be more aggressive? I know that the answer to this has not been solved about postoperative atrial fibrillation, but we clearly need to solve it. And what is the role of anticoagulation at the time of patients undergoing that do suffer atrial fibrillation? Is there a role for preoperative screening of carotid disease? And what is the role of dual antiplatelet therapy? One would think that after the first 30 days, these are the same groups of patients, the incidence of stroke should be the same after 30 days in both groups. Why was it not? One of the differences was, as I demonstrated, a significant higher number of PCI patients received dual antiplatelet therapy, raising the question, is that potentially protective about stroke? The same thing with statins, since there was a higher number of patients in the PCI treated with statins. Regarding the intra-procedural aspect of this, I feel very strongly that intraoperative epiaortic ultrasound should be performed. I mean, this is very simple to do. It takes about 30 seconds during the procedure to just assess the ascending aorta, and this is just a patient done last week in our institution. And a patient that has an aorta that looks like this should never be done on pump, shouldn't receive the clamp to the aorta, should be done off pump with clampless proximal anastomosis or all arterial grafting. I think that my takeaway of this trial is that the results should be a positive rather than a negative. It caused us to focus on what are some of the downside issues of CABG and help make us better. The other aspect that I mentioned is that 3 of the strokes occurred before the procedure. We should, let me go to that in just a minute. So the messages here are: screen the ascending aorta on all patients, perform off-pump no-touch aortic technique if disease is present in the ascending aorta, aggressive treatment of postoperative atrial fibrillation with possibly anticoagulation. We need to determine whether there's any benefit to dual antiplatelet therapy after CABG, as there is for multiple reasons after PCI. And there are further trials going forwards. There will be a new left main trial going forwards. And we as surgeons hurt ourselves in these trials. This trial plus the ARCH trial of waiting so long between the time of randomization to the time of surgery. The stroke occurs ahead of time, it still counts. We're hurting ourselves in the long term, so my plea is, please participate in these trials going forwards, and please don't wait so long between randomization and surgery. Thank you.
Michael, thank you for that very clear and very thought-provoking talk. And it raises the issue which has been repeatedly discussed at this meeting of EACTS, the role of 2 internal mammary arteries and the role of off-pump surgery. Our next speaker is Dr. Patrick Sarais, who is one of the co-principal investigators of the Syntax trial, and he's going to tell us now what patients he sends for CABG.